desktop gear number.
For those who are logged in online, can you please put your questions in the chat box? Could I request all presenters to move in stage so that we don't waste time, because we are sticking sharply to 12 minutes so we can close by 9 o'clock.
Good morning, everyone. I'm Rizwana, presenting on behalf of Medicine 3. The topic is a wicked bite. Presenting Ms. F, a 17-year-old college student from Kadapa, who presented with a chief complaints fever for 3 days, abdominal pain for 2 days, and altered mental status for 1 day. The history of presenting illness was she was apparently well 3 days back when she developed a fever which was high grade, intermittent with chills and rigors, and it was relieved with paracetamol. On day 2, she had developed abdominal pain, which was migratory. First, it involved the right upper quadrant, then to the right lower. Then it became diffuse. It was non-radiating and associated with vomiting. 2 episodes, which was postprandial, non-bilious, non-bloodstain. There was no jaundice, pale stools, or pruritus, or dysuria or flank pain. On day 3, in the morning around 10 a.m., she developed irrelevant talks, followed by drowsiness around 2 p.m. There was no loss of consciousness or seizures. Significant past history was she had a history of fever with jaundice 6 months back when she was hospitalized and told to have hepatitis A, which required 1 day of ICU admission and 2 days in ward, and then she was discharged. She was continued on treatment for 1.5 months, but the details of the medications are not available. There was no history of CAM intake. Personal history wise, she's unmarried, no addictions, consumes mixed diet and normal bowel, bladder habits, and sleep pattern. There was no history of jaundice in the family members also. Examination wise, she was drowsy but arousable. GCS was 9/15, E3, V1, M5. Other vitals were stable. On examination, she was not pale, anectric, no cyanosis, clubbing, or lymphadenopathy or pedal edema. There was a blanching rash present over the chest and the back, and there was some petechial rashes over the lower limb. CNS examination wise, bilateral pupils were equal and reacting to light. Extraocular movements were full. There was a lower limb asterixis. Otherwise, there was no neck stiffness, no meningeal signs. Fundus did not show any papilledema. Abdomen was soft, non-tender. Liver and spleen were not palpable. Trop space was resonant, and no shifting dullness. Other system examination was normal. So with this history and examination, we had differentials of septic encephalopathy and CNS infections like meningitis or encephalitis or metabolic encephalopathy. So we proceeded with the basic investigations, which showed in CBC it showed a thrombocytopenia with a normal leukocyte count, and an LFT showed an elevated liver enzymes in the range of 1842 SGOT and SGPT 1272. And the subsequent coagulopathy profile also showed a INR of 2.12 and APT of 52.5, and ammonia was 134. And the other parameters were normal, and RBBS was negative. CSF tapping was done, which showed a protein of 231 and a glucose was 80 in the CSF, and the plasma glucose at that time was 93. And total count was only 3, with a DC of lymphocyte 15 and monocytes 10. So then they did a CT brain in the ED, which showed diffuse cerebral edema and cerebellar edema with features suggestive of raised ICT. So the syndrome complex considered was an acute febrile illness with an acute liver failure. So I would like to ask some differentials from the audience side. The code is 2753028. You can share your differentials in the slide. The Slido, the differentials that are given by the audience were viral hepatitis, leptospirosis, rickettsial meningoencephalitis, acute Budd-Chiari, and viral encephalitis. So, proceeding here. So the differentials we considered were for the acute liver injury with the elevated liver enzymes of more than 1000, viral hepatitis, which can be a hepatotropic viruses with the background history of hepatitis, hepatitis A, B, E, and non-hepatotropic viruses like HSV, EBV, CMV, Coxsackie, dengue were considered. Since she also has a previous history, we also wanted to rule out autoimmune hepatitis, which the panel was also negative. And secondary, she can also develop acute liver failure secondary to drugs or toxins because she was on treatment for 1.5 months and in outside also. Then along with AFI with acute failure, we considered viral hepatitis, scrub and lepto as our main differentials. Further investigations revealed an dengue NS1 antigen positive on day 4 and other HIV, IgM HIV was low positive, HE was negative, malarial parasite, scrub, lepto were negative, serum dengue PCR was also positive. HLH workup was negative. And so we proceeded with the management. We got a hepatology consult and they asked us to proceed with a NAC protocol, NSTL system protocol, then anti-edema measures for the cerebral edema and vitamin K for coagulopathy. So basically we managed it supportively and her liver enzymes showed a decreased trend during the hospital stay. However, her sensorium did not improve with the treatment. Later, we again did a CSF analysis for the further workup for to rule out other encephalitis causes, which were all negative. It is negative for HSV, EBV, CMV, VZP, adeno, and cryptococcal antigen was negative. Acanthamoeba was negative. Culture did not show any bacterial growth. So we proceeded with a higher imaging MRI brain with contrast, which showed hyperintensities involving bilateral cerebellar white matter, thalami, dorsal brainstem, and bilateral frontal white matter with multiple scattered punctate foci of diffusion restriction within these lesions and diffuse supratentorial leptomeningeal enhancement also suggestive of viral meningoencephalitis. Ultrasound abdomen did not show any significant abnormality. So the final diagnosis we arrived was severe dengue with encephalitis as well as hepatitis. So the follow-up OPD visit, when she came, all her parameters were normal and she was completely fine. So here, since the diagnosis was encephalitis, and I would like to proceed with the neurological manifestations of dengue. Usually, dengue is not considered a neurotropic virus, but recently we have found out there is a neurotropic aspect also. There was a direct viral invasion in the CNS, possibly because of the blood-brain barrier disruption. And mainly dengue serotype 2 and 3 were traditionally involved in the neurological complications. In our patient, it was dengue serotype 2. The neurological manifestations are divided into direct neurotropism, which causes encephalitis, meningitis, myelitis, and myositis. Systemic complications, encephalopathy, stroke, and hypokalemic paralysis. And post-infectious can be acute disseminated encephalitis, GBS, and optic neuritis. So dengue encephalopathy versus encephalitis. Both presentations are similar. So it's very difficult to differentiate between a dengue encephalopathy and encephalitis. Usually the presence of CSF pleocytosis and abnormal imaging consistent with encephalitis and the antibody detection in the CSF or PCR detection in the CSF would favor an encephalitis more than an encephalopathy. So in the studies done, they had shown that most commonly the imaging, MRI imaging may be normal, or there can be a splenial hyperintensity in the corpus callosum, or bithalamic pontine or cerebellar involvement, cortical or subcortical involvement, or a meningoencephalitic pattern. These are the patterns seen in MRI in a dengue encephalitis. So this was from the frontiers where they had given us complications of neurological complications of dengue. In CNS wise, it can be encephalitis, encephalopathy, or meningitis. It can also cause stroke, can be ischemic stroke or hemorrhagic stroke also, cerebellar syndromes, then transverse myelitis and ADAM. PNS involvement wise, it can cause GBS with albinocytological dissociation and brachial plexopathies, hypokalemic paralysis secondary to renal tubular acidosis, and myositis is also one of the PNS manifestations. So the learning points are dengue should be considered in the differential diagnosis of AFI with neurological manifestations, especially in dengue endemic countries like ours, and with any recent history of travel to the endemic region. And one more take-home point is dengue virus has a neuroinvasive capacity also. And dengue infection can cause transaminitis, but with acute liver failure is also possible in a minority of cases. And the management is mainly supportive and the prognosis is better. Thank you.
Thank you, Rizwana, for a very interesting case with both neurological and hepatic involvement. So I just want to ask a couple of questions on, did the patient actually have ALF or was it primarily a CNS involvement which caused the altered sensorium? And do you want to discuss a little bit about why you chose to give NAC, which would not be a standard therapy in this setting? And you mentioned lower limb asterixis. I think it's the first time I've heard across asterixis being there in the lower limb. So you want to just explain that?
So firstly, dengue encephalopathy, encephalitis, that is acute liver failure, sir. Initially, since the liver enzymes were elevated, but the bilirubin was normal, sir, and we proceeded with further investigation. Ammonia was also elevated, 134. So we attributed the altered sensorium to the encephalopathy.
So were there other signs of liver failure? Did patient have coagulopathy, bleeding? Was there?
Yes, sir. Coagulopathy was also there.
Okay, but now in the light of the recovery of the rapid recovery of the liver functions, would you like to attribute the altered consciousness due to neurotropism or due to the hepatic involvement?
It can be both, sir, because initially there was a cerebral edema. We started anti-edema measures, but even after 5 days of anti-edema, cerebral edema was not resolving. Usually in a hepatic encephalopathy, there will be rapid development in improvement in the sensorium, but she did not improve. That's why we proceeded with the MRI and.
So you think both are there, but probably the direct involvement of the CNS was probably more important because of the MRI changes, the profound cerebral edema, and the NAC.
NAC was actually, it was suggested by the hepatology, but in the studies also show that non-paracetamol acute liver failures, NAC protocol is useful.
Yeah, so even in the area of toxicology, there's no solid evidence actually to support. It's a practice that is used, but it's not very clear. The low limb asterixis.
Yes, so during.
How do you elicit low limb asterixis? We know how to elicit upper limb asterixis.
Actually, in a normal sensorium patient, we can elicit a upper limb asterixis. In a patient with a lower sensorium, we can do a lower limb asterixis where you have to bend the knees. We have to keep both the lower limbs in the frog-like position, like knee flexion and external rotation. And when we keep the limbs in that position, there will be a downward flap of the knees it will be observed in the patient. Mostly.
Do you have a reference for this? Because I have not come across this.
Yes, there is about an asterisk in NCBI. There is a about asterisk they have given, sir.
Any other questions from the audience? If not, we'll go on. Thank you very much for a very interesting presentation.